I'm Dan Collins with Mercy Medical Center in Baltimore, Maryland, and you're watching Medoscopy. Thanks for joining us for today's procedure. Our guests are Doctors Matilda Hagan and Bryan Curtin of the Institute for Digestive Health and Liver Disease here at Mercy. Dr. Hagan, I'll start with you. Your focus is on inflammatory bowel disease, IBD. Now, this covers a lot of different conditions like Crohn's disease, ulcerative colitis, or UC. Is it me, or does it seem that we're seeing a lot more of these issues now? And if that's true, what's causing that in your opinion?
So it's certainly not just you. I mean, it's pretty well recognized that the incidence is increasing and has been over time. I think the thought is that as more countries become industrialized, that's one potential reason for it. And then there's questions about, sort of how there's more prevalence in northern areas versus southern areas, and whether or not sunlight exposure, vitamin D exposure, and/or deficiencies, and other environmental things that we just perhaps have not completely identified may be contributing. So no, it's becoming more and more not just greater incidence, but also a greater prevalence as people are living longer with it and things like that. So.
Do you find patients sometimes get confused with all the different issues, confusing their IBS with IBD, and what's the difference between reflux and GERD and all those different things? I mean, how do people kind of navigate that? How do you help them navigate that?
Yeah, so, IBS, irritable bowel syndrome, is quite common. I think it's, at least maybe 20% of adult population may have, and that's the people that perhaps come to see a doctor, which is different, and perhaps Dr. Curtin can get more into that. IBD, which is inflammatory bowel disease, I mean, you mentioned, and that typically encompasses ulcerative colitis and Crohn's disease. And then if we can fit them neatly into one or the other, they're called indeterminate colitis, which is more of an immune system based disease. IBS is just more of a nuisance condition, whereas IBD is something in the environment has gotten the immune system to then be turned on in some ways, or is reacting, and in so doing, it's attacking the lining of the intestine. So it has significant implications long term as far as cancer risk, disability, as well as other more serious things. Not to say that IBS is not important, but IBD certainly is something that most people can live with IBS and never really have any long-term complications per se, whereas IBD can have actually significant long-term complications, and that's the key difference and the reason why we have to treat it more specifically.
You're both gastroenterologists, correct?
That's correct.
Yeah.
Why gastroenterology? I mean, why was that an area that you both decided was like, this is something that I want to do, versus, say, becoming a vascular surgeon or an oncologist or an orthopedic surgeon, or, maybe something totally outside the realm of medicine? Dr. Curtin?
Yes, I mean, my journey to gastroenterology kind of took a very meandering path. I think when I first went to medical school, my exposure to, the field of medicine and science in general was mostly in a lab, doing like cell cultures and things like that. So I thought when I first got to medical school that I was going to be a pathologist. And then I got to see what pathologists actually do. And then I realized, maybe this isn't really what I want to do necessarily with the rest of my life. I was really attracted to internal medicine initially, just because I felt that it had the widest range in terms of disease processes, in terms of like dealing with patients on a one-on-one level. And so through internal medicine, then I got to meet a lot of really skilled doctors at University of Maryland for gastroenterology. And so they really kind of inspired me, I think, to go into gastroenterology. One of my mentors there also, I always remember this phrase, is that, when I asked him why he went into GI, he said, well, I really love playing video games. And GI is kind of just like a video game. You do scopes, you find polyps, you take them out, and you fix diseases by doing a procedure. And I like video games too, so it sort of stuck with me. And so it's a nice blend of doing both kind of like the traditional medicine side, prescribing medicine, seeing patients in clinics, but also doing procedures that really change people's lives. And so I think that's what drew me there.
So the allure of video games, was that the same in your case or something different?
I say similar. I actually also went to University of Maryland, and I think a lot of a lot of medicine, your ultimate decision as far as what you choose to do has to do with life experiences, but most importantly also mentorship and the people that you come in contact with. So as a med student, I actually decided in medical school I was going to do GI, and the reason for that was I had one instructor who was a gastroenterologist, and in fact he was a fourth year fellow, an advanced fellow at the time, and he was just really excited about his work. And so when I happened to have, on my medicine rotation, when I would have patients that had GI, problems, I got to, kind of not just interview them at the bedside, but follow along and go watch the procedures and have them explain. And time just went by fast when I was there. I mean, it didn't feel like work. So I was like, oh, maybe I should do this. Maybe I can do this. And lots of different things. I mean, you never know what you're going to find, when you talk to someone and you think you know what's going on. And then we have the benefit of, getting to, do a procedure sometimes to see if our thoughts about what we think is happening is really what's, what's going on. And so for that reason, it really made GI a very attractive, specialty. And I've been very happy, sure.
Yeah, I mean, it's a journey, I think. A lot of times I think, people look at doctors are like, when you're in medical school where you just like, forget about the heart and lungs, like, let's hear more about the butt, about the stomach and things like that. It really wasn't like that. It really kind of, you sort of, you find things that are a little bit interesting to you and then you explore deeper. You meet a lot of like mentors. And I think that's one thing we both touched on, like that kind of inspired you and sort of like really kind of showed you what the field really is about, and then you see yourself doing that, as a career, and that's sort of where we've ended up.
Dr. Curtin, what would you say that your patients say about you in terms of a physician? In other words, why do they like you? They want to come see you, in your opinion?
I think that I see a challenging patient population. So GI motility kind of deals with I think some of the more forgotten corners of gastroenterology. Most of GI deals with things that you can kind of see with your own eyes or that you can measure with a test a lot of the time. So, inflammatory bowel disease is a great example. You can see the inflammation inside the gut. You can get a lab test that sort of like, corroborates your hypothesis about what's going on. A lot of times for something like irritable bowel syndrome or other sort of similar, motility type disorders, it doesn't show up on the more typical tests. Like somebody can get an endoscopy, somebody can get a CT scan, and it doesn't necessarily show anything obvious. And so I think that, the biggest thing that I do for my patients when I first meet them is just listen to their stories, because a lot of times, when a patient, goes through the medical system, they get a workup and then they're told, well, there's nothing wrong with you, but they know that there are symptoms going on. That can be really challenging for them. And they can feel like, well, they don't believe me. They think I'm crazy. They think that I'm making it up. And that's really disempowering for a lot of patients. I mean, so the very first thing that I do, when I'm seeing a new patient in clinic is I just sit there and listen to their story for some time and say, there's lots of other people that are dealing with this, millions, in fact, that are dealing with these kind of symptoms. And I have a few more, tests and tools and technologies that we have access to now that I'm fortunate enough to have access to, where we can sometimes characterize things that have been overlooked or things that have been missed. But sometimes we just have to use the tools available to us. And I think that, my patients appreciate the fact that like I'm willing to sort of sit there, listen to their story, take them seriously, and address their concerns.
For me, and I completely agree with Dr. Curtin, in my training, I remember one of the things one of my professors said was that your patients will tell you everything you need to know to make an impact on them, or at least to be able to help them with whatever the problem was. So that's, there's a reason the history is part of, the first thing that we do in creating a medical assessment. And I think it's important, again, especially when they first meet you and pretty much subsequently after that, it's important to allow them to voice why they're there to begin with. What are they there to hope that you can, change for them? And I think once you do that, then you can kind of, take that information and, kind of filter it through our available tests and, what your, what your training sort of leads you to come up with in terms of what could be going on and what are the next steps, and then trying to get them to understand what you're thinking could be going on with them and why you're asking for the test that you're asking for, and hopefully walking them through that whole process and helping them understand this is why we're doing this, and this would be the next thing that we do, and this would be how we would treat you, and this is why we're treating you with this. And I think that that's really critical.
We talk a lot here at Mercy about patient-centered care, and I think part of that is the idea of the physicians working with the patients, that it's a team effort.
And in IBD world especially, there's a term that's been coined, which is shared decision making, and I think it's applicable to any part of medicine, which is that the decision has to be made together with the patient. They tell you what's going on with them. You tell them what the options are, and then together you can figure out what fits. Because there are sometimes we tell them, well, we can do this and this, and they're like, well, wait a minute, I don't want this. Like, I don't see how I can get through life with like this kind of operation or this kind of procedure or this medication and the potential side effects of the medication, particularly for my area where some of the medicines could potentially have certain side effects or whatever. And I think that's probably applicable in other areas as well. But it's important that the decisions are made together.
Yeah, I mean, it's really interesting that, as we've gotten so many medical advances, we have more technologies, more treatments, we know more about more diseases than ever before. But, as you pointed out, it feels like the connect, sort of that relationship between patient and doctor really has never been in a worse place in general. I think that back in, many years ago, doctors did spend a lot more time with patients. I think that there was a lot more of a connection, even though they didn't have as much information or as many tests, there was a lot more of like a connection, like a personal connection between those. And it takes a lot of effort to sort of maintain that. I think everybody has an experience going to the doctor's office where they feel like they're on an assembly line. The doctor is just sort of sitting on the computer, just kind of looking at the charts, trying to get all these different informations, get all these different like billing codes and all these kind of things together. And they're not even like looking at the patient a lot of the times. And some of that, as I said, I sympathize with doctors as well, because we're seeing a lot more patients than in the past. But at the same time, I do think it's important to sort of make that kind of effort. And I think that, Mercy is a great place for that. I think that the doctors here sort of make that additional effort to sort of have that kind of connection with the patient or to make those kind of decisions and treatment plans.
We'll take a break and we'll be back for the next segment of Medoscopy.
In general, we don't ever need to refer outside of Mercy's medical system for GI-related needs because we have all the specialties, and that includes surgical specialties as well with colorectal and general surgery right here in-house.
We are on the cutting edge of GI and liver disease, but we are providing that service in a community setting in a friendly manner. And we are assisted by some of the most well-trained nurses, technicians, and staff in this. So we are unique that way.
The number one goal of physicians, no matter what their specialty, is not just the treatment of disease, but the prevention of disease and complications of disease.
10, 20 years ago, people would just be kind of diagnosed with irritable bowel and they'd be sent on their way with no real relief. But now we have so many different tools to address, diagnose the problem.
We choose the exact intervention which is right for this particular patient. It has to be individualized care and individualized aftercare as well.
Figuring out what matters to them, addressing their disease in a way that keeps that in mind and that, showing them respect.
I give sufficient time to each and every patient and make sure all their concerns are addressed. And we have a plan formulated during the visit where both of us agree, and that's in the best interest of the patient.
Communication is very easy within our system. We're all sort of in the same area. There's less bureaucracy, there's less levels of people and things that a patient has to negotiate to get to the doctor.
Every day there are more treatments on the horizon, and I'm also excited that here at our center that we will be involved in some of those clinical trials to bring those therapies to the forefront.
It's treating your patients like family, treating them like you would one of your family members, and involving them in their care so they have some power in their outcome.
And welcome back to our next segment of Medoscopy. We're with Doctors Matilda Hagan and Bryan Curtin of the Institute for Digestive Health and Liver Disease here at Mercy. During the break, Dr. Hagan, you said there was a point you wanted to make, so I'm going to let you make it.
Yeah. So I wanted to, Dr. Curtin, when he explains motility and the syndrome and the symptoms that patients might have, earlier we talked about what is the difference between IBS and IBD. And I had sort of mentioned that IBD is an immune system-based disease, but the key distinction is that inflammatory bowel disease, there's actual damage to the bowel. When we do our endoscopies, we'll see injury to the bowel lining. When we look under the microscope, we'll see evidence of injury. When we do our CAT scans or MRIs or our capsules, there will be evidence of tissue damage, and that damage is over time what could put you at risk for cancer and other things. Whereas irritable bowel, there'll be no no damage to, to the lining per se. There'll be no abnormalities in your blood work, unlike inflammatory bowel disease, where there will be abnormalities like anemia and other things, or certain, nutrient deficiencies or vitamin deficiencies. You will not see any of that with irritable bowel. So that's one of the key distinctions, is that one process, because it's mediated by the immune system, we actually see clear evidence of damage, whereas the other one, we don't. It's more of symptoms, and that's most of the treatment targets the symptoms.
Yeah, and it can be kind of tricky sometimes. There's a lot of patients who, it can be a little bit unclear sometimes whether they have inflammatory bowel or whether they have IBS. In general, like inflammatory bowel will have like kind of more objective findings on the endoscopy or on laboratory findings and things like that. And so getting that patient to the correct diagnosis is so important, because again, a lot of patients, they can go off on kind of in a rabbit hole, so to speak, sometimes if they get sort of the wrong diagnosis, they get the wrong treatment. And that can be really harmful and really not good for their overall prospects going forward in terms. So getting that important correct diagnosis is very essential.
Dr. Hagan, on a more personal note, you have a rather interesting middle name, Nana Amba. Am I saying that correctly?
That's correct.
Okay. Now, what are the roots of that name?
All right, so I'm Ghanaian, and that's where that name comes from. And in fact, it's actually my great-grandmother's name. And Nana is sort of in this sense, it's a title, and it has to do with often like the chief or the queen mother would carry that title, Nana. Nana in Fantichi or the Akan people, you can use it to describe a grandmother, you can use it to describe a grandchild, but really when it's used as a title, it suggests like leadership. And part of that could be bloodline, or part of it could be if a person achieves a particular status and in the community such that the people in the community sort of look to them for leadership, then that's how they end up with that. But I just got it because it was my great-grandma. So.
Oh, that's wonderful. When you're both not treating patients, what do you enjoy doing? Do you have any particular passions or causes beyond the medical realm?
I think for me, I've got two kids. So my daughter Claire, 4 years old, and my son Max, 1 year old. So I think right now my biggest passion and cause is kind of getting them out of the house sometimes. It's my family has been such a big part of my life, and I think that it's important to have that kind of balance. When we're at work, like we're with our patients, we're giving 110%, in terms of making sure that the patients get the top quality care while we're here. But then at home, having that, I've been really grateful to have that kind of bedrock at home. My wonderful wife, my two kids, and so a lot of times, they're my passion sort of outside of work.